How do we shift our mindset that it's going to be much more costly? At this point of time, a pap smear is so much cheaper, Professor Wu, versus doing an HPV test. Affordability is a problem. How do we get around this problem?
I think we need to look at how much we spend or we invest in a woman in her lifetime. When we look at pap smears, we always look at it as a single test in a woman's lifetime. If we were to look at it as a protection throughout her reproductive years and as she's living, as she ages healthily, then we need to look at the investment in pap smears and HPV testing, and multiple studies have done. Those clever people with calculators, with maths and modeling have shown in all settings, whether it's a low income setting or high income setting, changing over to a HPV test is cost saving. That means it even works out using less cost to the government than pap smears.
I think that's right, and my background actually is as a cytopathologist. So prior to all these changes in the technology, I spent my professional career reading pap smears and running a very big lab in Melbourne that does 300,000 pap smears a year before we switched. And I know the amount of resource that it takes to do that accurately and to maintain high quality. It's very challenging and it's very costly in human resources. So I think sometimes governments look at the cost of proprietary consumables like an HPV test and they don't go back and say, well, how much are we spending on our laboratory staff doing these tests multiple times in a lifetime, and how much value are we getting from these tests? Because if they're not done at high quality, if they are truly very cheap, then I would have a concern about what's the quality, because you really need a person looking for a certain amount of time. They need to be well trained. You need to monitor their quality. So I think all of those things come together. And as I said, I'm a cytopathologist. I've sort of blown up my own profession.
I was just going to say,
Australia.
Your income, or how you would...
Our business model was completely disrupted by this change. And yet at the Australian Centre, we advocated for it strongly because we believe we're here for a purpose, and that purpose is to prevent cancer. And I want to be really clear that high-quality cytology has saved multiple lives over the years. It was important work and it was the best we had at the time. And so I'm not saying that that was wasted time, but I am saying now there's a better tool, and we have to be honest with ourselves and think about what's best for the communities we're trying to reach, not what's best for us as providers. And so that's why we really advocated strongly and worked with the government on advisory committees to give effect to this change that is putting Australia in a position where we might be first in the world, because we are reaching more people with a better test. And it's so exciting. But I'm not going to lie, it was really, really challenging. And it made some of my professional relationships not as collegial as I'd like them to be. And we were talking on the way over here too, that I used to have 50 highly qualified medical laboratory scientists who specialised in cytology. And we now have 12. So 38 people. We had to go through a process over 2 years about timing their retirements if they were going to retire, helping them develop their skills to work in other areas of laboratory science or in other related fields, and supporting them in other qualifications. And, I think at the end of the day, we have to do what's right, and we have to treat our workforce with compassion, but we can't make our decisions about how we spend public health money based on preserving jobs for people. That's just not the right choice.
I mean, we are in an era where we are reskilling and upskilling, and it's just one of those things, isn't it? We all go through it. I mean, we talk about artificial intelligence and how it's going to displace a whole load of people. It's similar right? It's all about retraining and finding your ground.
And I just want to say that one thing that's not talked about a lot in low resource settings, but I am aware of, is the shortage of qualified staff to do lots of things. So these people who are trained as cytologists, they've got great medical laboratory science skills. They can be redeployed in a number of different areas within med lab science, but they also can do other things like data management, health information management. Some of them have population health qualifications. So I think it's really important that we acknowledge that I think it's very unlikely that we're going to have a lot of unemployed people. We're going to have people who are going to go through change, which is going to be difficult. And when they're on the other side of it, I think they'll feel better about it. So we switched at the very end of 2017.
Okay, all right.
And that's the same story with clinicians and doctors as well. We are creatures that don't want change. We're trained in a certain way. I'm trained to do pap smears. I'm trained to do surgery for cervical cancer. And as a gynecological oncologist, that's really my rice bowl. And to say that, I'm now going to give you a swab, to do your own swab, and there's a probability that I'm going to be irrelevant, that's something that I have to think about, and how do I change my role in healthcare?
Yeah. What do you think? Where do we even start in Malaysia?
I think we're at a good starting point.
Yeah, we've
Meera.
done well with vaccination. We need to now build up the screening and the treatment part of the elimination program. How do you think we can do that, though?
I think Malaysia is in a very good place. There is political will. I mean, for our government, our Ministry of Health, to change their guidelines, to say that, yes, we are going to move with HPV testing. Yes, we are going to do self-sampling or offer self-sampling. That is even a point where many countries are trying to achieve. Now that we've take this little step forward, the question is, how do we get buy-in from healthcare professionals? How do we re-educate our women? How do we remove those fears? And that's where I think a call to action for everyone in Malaysia is necessary. Not just doctors, not just public, but even the financial sector, even the hospitals, how we do billing, how we package care. We do need to re-look at all that. How do we say cytopathologists, yes, you can be doing other cytopathology work in the laboratory. Okay, these machines, let's share them. You bought them for TB and HIV testing, but can you now use them to do HPV testing? I know we're very territorial, but let's look at ways to share these machines. We have resources. Sometimes I think that it's the way we separate our departments and our work description. I think we need to be innovative and change some of these policies, and it may not require so much investment because they are there.
We did a lot of PCR tests during COVID, during the pandemic. Can those be used?
I think if we look at it correctly, they can be used, and it's used in many countries. Because if you think about the flip side, we've had all these machines and we use them for COVID, and these machines are used for PCR. So choosing the right machine, we can definitely utilize these machines for HPV testing.
And as a pathologist, as long as these instruments are clinically validated for HPV testing, that's great, because then you don't have the capital expense of buying the instrument. You're then looking at the consumables cost for new tests.
What's clinically validated is what my colleagues ask all the time, Marion.
So HPV testing is interesting because unlike when you do a COVID test or other PCR, you're just looking for the presence of what we call a pathogen. So that's a virus or a bacteria or similar that can cause disease. But with HPV testing, because this infection is pretty normal and common, we're looking for enough of the virus being present such that studies show it's associated with pre-cancer at a certain level. So when we have HPV tests for primary screening, We need either trials that demonstrate that it's sensitive, meaning it'll pick up a problem if it's there, and as specific as possible, meaning you don't get too many positive tests when there isn't a problem there, for the detection of precancer. So we either need those trials or we need comparisons with other tests that have been in trials, and we need to demonstrate equivalent performance. So there are an international group of experts that have a set of criteria that the new tests have to demonstrate that they meet those benchmarks and they're suitable for screening.
So it can be done.
It can be done, definitely. And there's more than a dozen tests on the market internationally, close to 20, that have been clinically validated. So there is a lot of choice, and it's also important that we don't let cost drive the selection of tests that are cheaper but not clinically validated. That's really important. So the way it worked is the Australian government actually undertook a health technology assessment. And that means that the cost and the benefits of screening with pap smears was compared with the costs and the benefits of screening with an HPV test. Now, I've been involved as an expert on these committees for a couple of decades now. I've seen many applications for new technology to improve the accuracy of screening by cytology, none of which have succeeded in the Australian context. And this is the first time in my life. So to answer your question, what our government and many governments do is we compare the cost per life year saved. And that's how you can compare the investment in screening against improving neonatal health services. And there's usually what is called a willingness to pay threshold that most governments have. So not only did this switch make that hurdle, but in fact, what was shown with the cost effectiveness analysis is the cost of screening with HPV, even taking into account the extra costs of the test, was less expensive over the lifetime than the cost of doing cytology because of the number of tests required in a lifetime. So less expensive and more effective. And you just practically never see that. In health economic terms, I've never seen it. It's definitely a unicorn to have something that works better and costs less. And honestly, there aren't health ministers or governments that are going to say no in that situation.